I have to, so I have nothing to disclose. And today we're mainly going to be talking about a lot of different cases of scenarios that you might encounter, mainly in the inpatient setting, but they apply to a lot of others, the outpatient setting as well. Yeah, so we'll just start with the cases. So this is the first case. 73-year-old man with COPD on nasal cannula chronically, heart failure with reduced EF, DVT on a DOAC, type 2 diabetes. It's day one of their CAP treatment. They're on azithromycin and ceftriaxone. You're cross-covering. You get paged about a fever. They do have a fever, 38.5, but they're otherwise stable. Nothing has changed. And yeah, so your question is, what do you do next? And I think there's a poll that's going to pop up. There it is. This is case 12. So let me go back to case 1. Launch. All right. Excellent. I'll wait till there's like till the choices stabilize here, and then I'll release the poll. Excellent. All right. I think it's stabilized. And I think by Emily, by clicking end poll, that releases it, right? Or share results. Okay. Or you did that for me. Okay. Thanks. Excellent. So I don't know if everyone can see this, but it looks like we have a split between option A and option E. So the answer, in my mind, would be option A, evaluating the patient. And we'll talk a little bit about that in a sec. So, there's nothing inherently wrong with ordering those tests. The issue arises when we order them without first considering the patient's clinical presentation, because a positive test can lead us to treat the wrong diagnosis and also delay treatment for the correct diagnosis. So this chart below is from a survey of first through 4-year IM residents at UCLA. And they basically asked them about the full fever workup in terms when they cross cover. So surprise, only 11% of them evaluated the patient, but around 50% ordered all the tests included in the full fever workup. And you got to be careful with that because radiologists often hedge a little bit on their chest X-ray reads, and there's data to say that ambiguous reads lead to antibiotic overuse. Similarly, your blood culture yield depends on your presentation. So when you have a patient that's immunocompetent with only a fever and no other symptoms, your blood culture yield is very low, around 1%. And then, as we know, asymptomatic bacteriuria is a huge issue. And this is just data from the VA where we basically treat around 72% of patients with asymptomatic bacteriuria, just because it's really hard to not be tempted by that positive culture when you see it. So how should we evaluate a patient overnight? So my suggestion is to use this head-to-toe approach to build a differential diagnosis and then determine which diagnostic studies you need to order based on your differential. And in terms of when to start or modify antibiotics, I usually start by asking myself if there's a suspected infectious cause or a source. And if there is, I target that source with my empiric agents. And if there isn't, then I try to figure out how sick the patient is. So if you have a stable, non-neutropenic patient, it's okay to send off your diagnostic studies and kind of hold off on the antibiotics. But as they start having increased illness, so if they have organ dysfunction or are neutropenic, then you start thinking about broader coverage and covering any gaps that they may have if they are already on antibiotics. And obviously, if they have shock, i.e. they're needing pressors despite fluids, then very reasonable to be much broader with your coverage at that point. And yeah, these are all very short. So if there's questions, please put them in the chat and I'll answer them as they come. All right. Next. So case 2. This is an 87-year-old woman with heart failure with reduced EF. She's a SNF resident. She has fever, cough for 3 days. She's febrile. She's very tachycardic. She's hypotensive. She's 87% on room air. She's alert and oriented ×2. Has a little bit of an AKI. Leukocytes are low. Has a high lactate. She had a positive MRSA and Aries 9 months ago, but no recent hospital stays. And here it's asking you what your empiric coverage should be. And I think I gave a very similar case when I did the ASP talk a few weeks ago, but I have changed something in this case. So something to watch out for. All right, I think we can share the results. Perfect. So it seems that it's actually pretty well distributed. It seems like option B has around 40%. Then options A and C have around a quarter each. So the answer for this one is option B. So most of you got it. Excellent. So this is a question about when to add empiric anti-MRSA and anti-Pseudomonal coverage for CAP. So the 2019 ATS-ADSA guidelines have a lot of tables that are pretty nice at guiding you through this. But I prefer this algorithm. It's a little bit simpler. It was made by one of my fellowship program directors over at UCLA. And it's a little bit easier to follow, at least for me. So if we look at our patient, the first thing you do is determine the severity of their CAP. So she had severe CAP by the ATS-IDSA definition, high respiratory rate, confused, BUN, and leukocyte count below 4,000. So you kind of go into this part of the algorithm. And then you ask, did she have any recent hospitalization with IV antibiotics, particularly in the last 3 months? And the answer to that was no. But she did have a prior positive respiratory culture for MRSA, which includes the mercenaries. And in the guidelines, they make, they cut it off at 1 year, although there's limited data as to how far back you can go. But she was yes, and therefore she gets anti-MRSA coverage in addition to the azithromycin and the ceftriaxone that everyone gets. And let's talk a little bit more about these predictors for MRSA and Pseudomonas detection. This is a question that's been around for like 20 to 30 years at least. And in more recent studies, the most consistent predictor of MRSA or Pseudomonas detection is a prior positive respiratory culture with those organisms. This is just data from study of around 40,000 admissions at several VAs. And kind of the take-home point is that having a prior positive culture for these organisms is the strongest predictor for getting them, for isolating them when you have a patient with CAP. The other kind of a stewardy finding to highlight is that there's a disconnect between what the risk factors are for detection and the risk factors for coverage. So basically, we overtreat a lot of patients for MRSA and Pseudomonas when they don't have those risk factors. And the ATS guidelines made a lot of, IDSA guidelines made a lot of, they discussed that they encourage hospitals to find other locally validated risk factors. And that's still an unanswered question as to whether or not there are other risk factors that predict detection of these organisms in addition to a positive respiratory culture in the past. And this is just a list of retrospective studies trying to answer that question. And you see, and they're mostly in MRSA detection. And things like tracheostomy, chronic pulmonary disease, being an event long-term have been associated with detecting Pseudomonas. The thing to remember, though, is that these are all single-center studies. And since microbiology is local, what's true for a hospital in New York near a bunch of LTACs may not be true for a hospital, a community hospital here in Seattle, right? So that's something to kind of take into consideration. Every hospital needs to have kind of its own list of validated risk factors. The other thing to consider is that when a patient's admitted to the hospital, with CAP, we're not great about collecting sputum cultures in most patients. So maybe all these cultures are just of the patients that didn't get better right away and therefore needed more studies. And lastly, at least in my mind, a patient with a tracheostomy or a vent technically can't have CAP, right? Because you have that prosthetic material in there that changes your microbiology a little bit. And the last thing I'll say about CAP is that a shorter duration of treatment has been repeatedly shown to be non-inferior to a longer duration. So many years ago, we would treat for 10 to 14 days. That was cut back to around 7 days, in the early 2010s. And more recently, there's a few studies that show that a duration of 3 to 5 days might be sufficient. So for immunocompetent patients without any complications, such as empyema or abscess, or any specific infections due to these organisms, 5 days, as long as they clinically improve, is sufficient to complete your course for CAP. All right. Again, if you have any questions, feel free to post them in the chat, and we'll get to them. All right. Next case. Should we be trying to get respiratory cultures if we suspect pneumonia? Are there issues with contamination? That's a great question. So yeah. So if you have a patient with severe pneumonia, so going back to this slide here, so it kind of depends on the severity and whether or not you're anticipating kind of a drug-resistant organism, right? So every patient with severe pneumonia, meaning those patients that are going to the ICU, gets blood sputum cultures. That's pretty straightforward. Your outpatients generally don't get them, but your inpatients, if you're either thinking that you might start vancomycin or cefepime down the road, or if you have started them, they should also get sputum and blood cultures. So I hope that answers that question. Yeah. Great. So going back to case 3. So this is an 88-year-old man with Alzheimer's dementia, also heart failure with reduced EF, COPD, type 2 diabetes. They have an indwelling catheter for neurogenic bladder. And then, they are admitted for altered mental status and failure to thrive. They're clinically stable, afebrile. They have a little bit of an AKI. Their sodium's low. Their leukocytes are 11. What do you do next? Do you get a UA with reflex culture? Do you correct AKI and hyponatremia, or do you do both of those things? And while you guys answer, I'll answer this question in the chat. All right, great. So for case 3, we have, all right, I think we can share the results. Great. So we have great. I like these. These are very controversial questions. I like them. We have a tie pretty much between B and C. So the answer, at least for me, would be B, right? And we'll talk about that in a little bit, and in this slide, actually. So, getting a UA with a reflex culture in patients with altered mental status, especially if they have a catheter, usually leads you down this cascade where the UA has pyuria and it reflexes to a urine culture. And that usually shows bacteriuria because they have a catheter. And then that leads you to kind of anchor in this UTI diagnosis and give unnecessary antibiotics, right? So the push here is to reframe that in patients who are stable and have altered mental status, to reframe diagnosis of UTI as a diagnosis of exclusion. So if your patient has AMS and is clinically stable, it's totally reasonable to correct all their other metabolic or other abnormalities that may lead to altered mental status before reaching for that UA with reflex urine. And I'll just chat a little bit more about management of UTI in general. So, back in 2010, 2011, the IDSA came up with a couple of guidelines for management of UTI, and they introduced this concept of complicated and uncomplicated, which is a little bit hard to remember because complicated has like a lot of line items to them. And it often can lead to overtreatment, mainly for men, because by virtue of their sex, they always have a complicated UTI, right? So a simpler way to think about UTIs is to determine if they are lower or upper based on the patient's symptoms. So lower UTIs being like cystitis, just bladder symptoms, and upper UTIs being pyelonephritis, sepsis, renal abscess, things that have more systemic symptoms or symptoms located to the kidney. And preferred, and there's always, you always have to remember these atypical scenarios. We talked about the altered mental status and when to order and treat. SCI patients also have some specific symptoms that we don't see in other patients, like autonomic dysreflexia or spasticity. And then treatment or empiric treatment. If you don't have previous cultures to guide you, you want to target enteric bacteria, so the Enterobacterialis group. So for lower UTIs, Preferred treatments are nitrofurantoin, second-generation cephalosporins, which still have great coverage against E. coli, and also Bactrim. And then when you're dealing with an upper UTI, you reach for the Bactrim, the fluoroquinolones, and the third-generation cephalosporins. In terms of duration, duration of treatment for lower UTIs can be anywhere from 3 to 7 days, depending on the antibiotic. The data on treatment duration for men is limited, so they always get a couple more days. And for upper UTIs, if you're using a fluoroquinolone or a Bactrim, 7 days is sufficient. And once more, data on duration of treatment for oral beta-lactams is limited. And in some studies, it has shown an increased relapse rate with shorter durations. So if we're using an oral beta-lactam for an upper UTI, we usually do a little bit of a longer course of treatment, 10 to 14 days. And what do we do for, this is a question that we sometimes get asked, what do we do with a patient with an upper UTI who also has bacteremia due to an enteric gram-negative organism? And traditionally, we would treat these patients for 10 to 14 days. But as of 2018, 2019, a couple of large retrospective observational trials showed that immunocompetent patients with Enterobacterales bacteremia who clear their cultures rapidly within 3 days and have good source control, and usually that means just removing the Foley and making sure there's no abscesses, prostatitis, things like that. A 7-day course of treatment is as good as a 14-day course in terms of recurrence and mortality. In these studies, most patients got IV third-generation cephalosporin, and some got fluoroquinolones or Bactrim. Over the past couple of years, there's been a little bit more data about using oral beta-lactams as step-down therapy. I think most will still reach for a Bactrim or a fluoroquinolone for step-down therapy. But if you ever use oral beta-lactam, make sure you wait around 4 to 5 days before making the transition from IV to PO, and also pick one that has high bioavailability, and also use a higher dose of that agent. But that's kind of where we are in terms of this topic. This might change as we get more data down the road. All right. And let's do the next one. All right, so this is a 43-year-old man with a history of IV drug use who's presenting with an arm abscess. They're febrile, pulse is 92, blood pressure is 141/81, no joint pain, intact range of motion, their leukocytes are 11. What do you pick? Excellent. All right. Great. Again, man, we have a scattering of answers, but I think most people picked C, which is what I picked. So let's go through that. So let's talk about the microbiology of SSTIs, right? So you have two types of SSTI, purulent SSTIs, which are, furuncles, kind of abscesses of the the hair root, or furuncles, which are just which are those furuncles but just coalesce together, or abscesses, which are a little bit deeper in the subcutaneous tissue. Whenever you drain these, about 80 to 89% of the time, you get Staph aureus. So that's the primary microbiology of a purulent SSTI. Non-purulent SSTIs, and these are things like, impetigo, that kind of honey-crusted rash with a red base to it, or ecthyma, which is the same thing, but just in your legs, or erysipelas or cellulitis, right? So without any pus component to them. Most of these are caused by group A strep, strep pyogenes, other beta hemolytic strep, and then a smaller amount caused by Staph aureus, and a good portion of that is MSSA. So, again, guidelines for these, right? So the treatment of these depends on the type of SSTI, purulent or non-purulent, and the severity of infection, which is mainly based on previous treatment and the presence of systemic symptoms. So in general, patients with a purulent SSTI will get antibiotics targeted against MRSA. So things like Bactrim, Doxy, vancomycin. And patients with non-purulent SSTIs get antibiotics targeted against strep pyogenes or group A strep. So Keflex, cycloxacillin, or cefazolin. And our patient in particular had a purulent SSTI. They had no systemic symptoms, so they could consider mild. In the guidelines from 2014, they suggest that an IND would be sufficient for these patients. But since the guidelines were published, there's been a couple of our RCTs that show that maybe a short course is needed for most patients with a purulent SSTI. So here's just a list of those two RCTs. And essentially, once you drain an so they basically took patients with mild SSTI treated as an outpatient that had an abscess of at least 2 centimeters. And they either gave them, an antibiotic, Bactrim or clindamycin in the other study, or placebo. And they noticed that patients that got an antibiotic against MRSA had more clinical cure and less recurrence and less infections in household contacts. And in a different analysis, a post hoc analysis of that, they found that difference in cure rate persisted for all kind of abscess sizes. So, in a patient, so my approach now is to consider 5 to 7 days of an adjunct Bactrim or Doxy after IND in patients with mild cellulitis. If they have an abscess that's more than 2 centimeters, it's incompletely drained. They have concurrent SSTI. So basically, everyone gets a little bit of inflammation right on the abscess and right around it. But if they have inflammation spreading beyond that, if it's in a specific location, like the face, the finger, perirectal area, if they have any risk factor for, complications of a bacteremia, if they're very obese, and that has to do with the dosing of the Medicaid, with that, a lot of the dosing, or if they're immunosuppressed, or if they have failed therapy before. So that's a little tidbit on that. And again, let me know if you guys have any more questions on that. And then in the meantime, we can move to case 5. I might actually get through a lot of these, Emily. I feel like we're doing okay on time. So the next case, 43-year-old man with history of IV drug use. Is actually the same patient as before. They had their IND of the abscess. They got 7 days of Bactrim. 2 days later, you get a call, their culture grew strep pyogenes or group A strep. What do? Do you add Keflex? Do you change to Keflex? Do you change to linezolid? Or do you continue Bactrim? All right. Great. Another kind of uh, a couple of responses here. So B, change to Keflex, or D, change to Bactrim. Great. So you could change to Keflex. Oh, I guess I'll share the results. People can see them. All right. So you could change to Keflex. That would be very reasonable. But you could also continue Bactrim, and I'll tell you why. So, most of us have been taught that TMPSMX doesn't have any activity against strep pyogenes. And if you look at Sanford, other sources, you'll still see that cited. I think even the guidelines cite it. That is actually a bit of a myth. And the reason why is because if you look at the mechanism of action of Bactrim, is that it acts on the folate pathway to prevent production of DTMP, which is a precursor to an amino acid that's important in DNA replication, right? The thing is that thymidine gives bacteria an alternate pathway to produce that amino acid and DNA. And before 2006, most susceptibility studies of strep pyogenes use media that contain high concentrations of thymidine. And that, as I said, would give bacteria an alternate pathway for DTMP production. Once you use more of a standardized lower concentration of thymidine in studies since, around 99% of strep pyogenes isolates are susceptible to Bactrim. And that's actually been brought to bear in a few clinical studies that have shown that, in patients with mostly strep pyogenes infections, they didn't have different cure rates between Bactrim and Keflex. So something to remember. Again, it's just something that we are taught that's not really true. Right. Next case. So this is a 51-year-old man with type 2 diabetes. Their A1C is 9. They have peripheral neuropathy, charcoal arthropathy, and a chronic right plantar ulcer. They're admitted for debridement of the ulcer and maybe an amputation. They're afebrile, they're stable, their ulcer probes to bone. They have mild erythema, edema just around the ulcer, a little bit of a leukocytosis, high ESR, high CRP, and then some erosion under X-rays. Yeah, what empiric antibiotics do you use? All right. All right, I think everyone has stabilized. Seems that E is the most popular answer, followed by D. and C. All right, perfect. So I would have picked E. Great. So let's talk about why. So first, let's look into the microbiology of diabetic foot infection in the US. This is just a list of studies that have looked into that over the past 50 years now. So since the late, and then the yellow highlights indicate the most common organisms in each study. So this is just to show that since the 1990s, the most frequently isolated organisms have been Staph aureus and some kind of strep species. So we'll save this for when we talk about the empiric coverage part. The guidelines on diabetic foot infection that were updated this year recommend empiric treatment based on the severity of the DFI, and they do a very nice job, kind of categorizing different stages of severity. And that usually depends on the extent of the local infection and the presence of systemic symptoms. One thing that is a little bit confusing to me about the guidelines is that they consider a DFI with any bone involvement to be moderate, but they don't distinguish between acute and chronic or stable bone involvement. So the case that I showed represents a very frequent scenario of a stable patient with a chronic ulcer that has mild symptoms and underlying osteomyelitis. And unfortunately, most of these patients get broad antibiotics pretty soon after they're admitted because technically they have a moderate infection, right? But patients with chronic osteo are usually stable. We can watch them. And therefore, it's very reasonable to defer the antibiotics until after the amputation or the debridement to increase the yield and the accuracy of your micro. So, I think that's why the answer to that question was E. Once you decide to start empiric treatment, if you remember back to the slide on microbiology, use that to kind of guide your coverage. I always try to cover MSSA and strep, even if it's a mild infection. And as the infection gets more severe in terms of systemic symptoms or extent of lesion, or if I find things like pus, ischemia, necrosis, then I add additional coverage for enteric organisms, anaerobes. And one thing to remember is that you don't always need MRSA and pseudomonal coverage. Specifically pseudomonal coverage, and there's actually several studies where they have looked at treatment with non-anti-pseudomonal agents compared to treatment with pseudomonal agents, and there has been no difference in the clinical response with either group. Excellent. So the next few questions are about bloodstream infections. So, it's Friday afternoon. This is I don't know about other hospitals, but this happens at the VA frequently. So it's Friday afternoon. The echo tech can only do one more echo before they leave. 4 of your patients are bacteremic. Which of your bacteremic patients should get that last echo? You have the 63-year-old woman or man with CAP, wine blood culture with strep pneumo, the 61-year-old man with pyelonephritis with 2 cultures of E. coli, the 72-year-old man with a TAVR who has S mutants in their blood, and 46-year-old woman with CLABSI and 1 blood culture with Enterococcus faecium. Awesome. All right. This one was less controversial, so I think everyone picked C, which is what I would have picked. And let's go over why that's the answer for this one. this goes back to the question of what is the pretest probability of endocarditis in patients with bacteremia? And that largely depends on the organism. So here is another list. I like lists. Sorry about that. But essentially, this is looking at studies of patients with bacteremia of different types and the prevalence of endocarditis in those studies. So if you go back to before we had widely available penicillin in the 1940s, about 70% of patients with Staph aureus bacteremia had endocarditis. That has since decreased, but it's still pretty high. It's in the 10 to 15% range. The same goes for Staph lugdunensis and for patients with other coagulase negative Staph bacteremia without any prostatic material, that rate drops pretty significantly. When you look at streptococcal species, some species are more strongly associated with endocarditis than others. So this is a study from a Danish study that looked at around 6,000 patients with different types of strep bacteremia. So, if they're red, that means that the association between that species and endocarditis is higher. And then the size of the dots just means how many cases there were. So the bigger had more cases. So things like strep galolyticus, which used to be called strep bovis, strep gordonii, strep mutans, strep sanguinis have very high associations with endocarditis, whereas things like group A strep and strep pneumoniae, not so much. When you look at other gram-positives, specifically Enterococcus, you find that E. faecalis has a higher association than E. faecium. And Haysick organisms can be at the rate of endocarditis in those can be up to 50% compared to other organisms. The thing to remember that is that these are retrospective studies, so there's confounding there, right? Then there's other risk factors in addition to the organism, things like having multiple cultures or prolonged bacteremia, usually more than 48 to 72 hours. Anytime you have prosthetic intracardiac material, that really increases your chances. Previous endocarditis, duration of bacteremia before it was detected, mainly because you had more chances to have things stick to places where you didn't want them to stick. And then other signs of dissemination, so embolic phenomena, metastatic infections, and also if there's no other source for your bacteremia, right? These are all things that increase your pretest probability. So, the way I think about getting an echo is on a scale from, 1 doesn't simply get a TTE to please tell me you got the TTE already. I have a very low threshold. I always get an echo for Staph aureus and Staph lugdunensis. I have an extremely low threshold for these strep species and Haysick. And then for things like strep pneumo, strep pyogenes, coag-negative Staph without cardiac material, or GNRs without cardiac material, or Candida without cardiac material, you really have to twist my arm to get a TTE. Everything in between, you have a little bit more leeway, and that depends on your other modifiers.
Well, I think this has been so helpful. I think I just want to acknowledge that we've made it to our 11:45 cutoff time. Yeah. Great. So we might have to call it here with the endocarditis workup. But if you don't mind, Luis, if you can pull up your very last slide so we get to the QR codes, people can do some evals, that'd be wonderful. I know that everyone is probably hoping to take a look at these afterwards. So they will be posted online at the ITC website, which I'm sending the link out. And then we also will send out the YouTube playlist recordings. So thank you so much. We can hang tight here for a minute or two for any questions. And a lot of information. So thank you again.
Yeah, of course. And feel free to reach out to me if you have any questions, and I'll send you I mean, I think you have a copy, but I made a couple of quick updates, so I'll send you the updated version. But
Sounds good.
all right.